Good afternoon, everyone, and welcome to Policy Exchange for the second of three events that we're holding today. This one is obviously on social care. Thank you all for coming. My name is Will Heaven. I'm the Director of Policy here. And in a previous life at The Spectator, I was a journalist who came up with the phrase Dementia Tax to describe a particularly bad social care policy that was unveiled in the 2017 election. And so my penance for the last year or so has been to try and come up, under Warwick's direction, something better than the Dementia Tax in 2017. I think one thing I would flag is just how important social care is to the public. In terms of what we want from the next Prime Minister, it's pretty clear that the public wants them to act quickly and do something. Social care, we asked the public in some polling earlier this month, we asked the public to basically rank areas of public spending their highest priority. And the public ranked social care second only to the NHS, so above education, benefits and welfare, the environment, defence, transport, international aid. So it's pretty clear that the new Prime Minister, as well as Brexit and all of that, should put social care pretty high up on the list. So we will, just to introduce the panel quickly, Warwick Lightfoot, who will speak first, is the head of our economics unit and the author of our social care paper, which we published just a few weeks ago. Lord Lipsey was a member of the Sutherland Royal Commission on the funding of the long-term care of the elderly. Jacob Rees-Mogg MP was very kindly agreed to write the foreword to our recent paper and was supportive with that, which we're hugely grateful for. Camilla Tominey, who has appeared on a Policy Exchange panel on this subject before, Associate Editor of the Daily Telegraph, and finally Sally Warren, Director of Policy at the King's Fund. I won't take up any more of your time and ask Warwick to speak first, 5 minutes or so each. Thank you.
Just give me a shout when you want me to shut up. This paper we've produced, 21st Century Social Care, has been the result of a large piece of work the Policy Exchange has done over the last 18 months or so. You can all hear me okay? Good. I thought I would just start by saying essentially what the number of the issue is, because at least we can all agree on that, which is that when the National Health Service was set up in 1948, it was accepted that any kind of clinical care, any medical care, will be free at the point of use. So if you see a doctor and the doctor comes to the conclusion that you need some kind of medical intervention, that intervention you won't be charged for in the main, except prescriptions and maybe some aspects of dentistry and so on. And however, at the same time, legislation was put on the statute book for social care. It was the National Assistance Act. And that's where it's not medical care really, but it's needing a hand to clean your house, get your food, have a wash, get dressed, all the looking after things that you actually need to have done to yourself. And of course, the big difficulty is that you can actually have some very, very minor clinical issues dealt with freely. So you won't see it, but that's a ganglion cyst. Now, I can have that operated on for free, but if I were to keel over in front of you now and faint, and it would be something really nasty, like a stroke, and I need in long-term care at home or in a care setting, I will actually be charged for that until I conform to a very stringent means test, and that would involve, if I was going to a long-term care setting, involve all my assets, including the value of my house as well. Now, that disjuncture means different conditions and different diseases, which are pretty awkward for the person, get treated in a different way. And of course, you have the oddities. I started out by saying you have something relatively minor being done for free, but something very complex and very serious being charged for. When economists look at this, and I'm an economist, and I first got interested in this in the 1990s, at a time when there was a very sophisticated debate on healthcare policy in the United States, you try and work out what can individuals do for themselves, what can they use private insurance markets to do, and those things that they really can't manage on their own. Now, many people would be able to visit a GP and be charged for that visit. Many people would be able to take out a very basic insurance of the sort that I have to do a hip replacement or a cataract or something like that. But in this country, we say, don't worry, these are things we will collectively provide for you and pool that risk collectively. And yet there's one aspect of the continuum of health and social care where you can't very easily get reliable insurance, and we say you're on your own, you've got to foot that bill yourself. And it's very interesting in the United States that makes much greater use of insurance markets. That's one aspect of the healthcare continuum where Medicaid makes much more generous assistance to households, particularly in the way it scores its means test and the capital component of it, than we do. Now, this poses very real problems for households because many households that you wouldn't normally think as particularly well off or rich, with a house worth £190,000 and some cash in the bank, finds that they actually effectively cleared out until they're down to something more like about £25,000. And so it poses a very real problem for people in their everyday lives at a very awkward time in their life and for their families. So policy exchange proposal is that we should actually fund long-term social care through general taxation, and we shouldn't actually charge people for that care. There may be scope for a limited co-payment, but you will be put through a test that assesses your care need, and if you meet that test, the care will be provided and you will not have the kind of full economic recovery of cost that happens at the moment. So this will be a very, very big change in our approach to these things. But there are a couple of additional things I'd like to say before I end that are part of the story here. We also take the view in the years going ahead, the balance of resources going into health, acute medicine, community medicine and social care will probably have to change in the years going ahead. There's got to be much greater priority given to community-based medicine, managing the diabetic leg ulcer in the community, into social care, than there has been in the past. And that will take time to do, and it's a direction of travel which will go in. Successive ministers of health, going right back to Sir Keith Joseph and Dick Crossman, have talked about this, but we've got to do much more in that direction. And the other thing I would say is that I've changed my mind about the role of technology and innovation. If we'd been having this discussion 2 years ago, I would have said there's no way technology is going to play much of a part in this. I genuinely think robotics and AI will offer scope to do things in a different way and probably in a better way. But let's not forget that a lot of technology and its diffusion is very, very mundane. And so, for example, changes in material science, in textiles, have transformed the management of incontinence. If you talk to a sentient 90-year-old about their experience of actually living with that challenge, and they compare it to their own mother, say 20 years ago, they will tell you that there's been so much improvement, and it's also diffusion of knowledge about what is available as well. So I hope I'm ending on an optimistic and upbeat note. These are challenges we face, they're tractable challenges, and I think that we've got an agenda that it reflects the gravity of the challenge and fills a lacuna in our welfare state, and in practice would complete the welfare state. So I hope you find the paper interesting, and I know you're going to have an interesting discussion with the panel.
Thank you, Warwick, and thank you to Policy Exchange for inviting me. Well, first question we were asked to address is, should this be a priority for an incoming Prime Minister, by which I take is meant Boris Johnson? And my own answer to that is absolutely not. Boris Johnson, I don't know terribly well, but Boris Johnson does not have a reputation for being somebody who gets deep into something and has tremendous command of detail and whatever. And this subject is the most complex I've ever grappled with, and I've been doing it for 20-odd years since I was on the Royal Commission. Indeed, the Royal Commission of 1999 made such a hash of it that nobody has set up a Royal Commission since. Now, I signed a minority report, which broadly was against the position taken, I think, by everybody else on the panel, that care should be free, and I just want to explain why I still believe that to be the case. Indeed, I believe it even more strongly now than I did then. There's a tremendous basic confusion here. I'm trying to put it in terms as simple that the future Prime Minister would understand, between two separate issues. One is how you provide adequate care to older people, particularly to older people who are less well off. The second and separate one is how care is paid for, to use the jargon, co-payment, whether people should have to contribute to the costs of the care they receive. Now, those two issues do overlap a bit, but to me, the first of those issues is by far the most important, in which we face something of a crisis. Local authorities' spending on care has been slashed because of largely of cuts in government grant. The result is you only get care if you have substantial care needs, while before, critical care needs, whereas before you got them if you had substantial or even moderate care needs. And you often get a visit for 15 minutes, 10, 15 minutes a day, whereas you used to have somebody who'd come and have a bit of a chat. In the care home sector, care homes are going out of business at a rate of knots because the amount local authorities pay to sustain their people they're paying for in care homes is simply not adequate to meet the costs, and better off people are paying for that by having to pay higher fees to cross-subsidise the local authority people. The way we treat older people is a disgrace to us as a society. There are organisational things that need to be done about it, better coordination, for example, between the health service and local authorities. Most of all, it needs more money spent on the public bit of social care, and I think on that we probably would reach a measure of agreement. But the question is, and it subtly lies into this, should this be free, like as the health service rightly pointed out here, is a point of use, or should people pay for it if they've got the means to do so? I can't go into the full detail of this yet, but first of all, let it be understood, free care for all is wildly expensive. Estimates go up to £17 billion. Now, if we have an extra £17 billion for expenditure now, would we want it all to go to paying for social care for better off people who at the moment have to pay for it themselves, or would we want some of it to go to education because that's going to determine how resources we have for social care in the future, or defence so that the Russians don't trample all over our older people so that social care is irrelevant? In any real cabinet, there is not going to be a sum of that scale available for social care, and I think it is much more important it is spent on better social care for the needy than to, in effect, subsidise the better off, or in fact, rather to subsidise their heirs, because let's face it, if the proposals in the manifesto are a dementia tax, the proposals for free care are in fact an inheritance subsidy. What they do is they allow people to leave more money to their descendants than they otherwise would. Second thing, basic economics. If you reduce the price of something from quite a lot to zero, the demand goes up tremendously. Why look into the crystal when you can read the book? In Scotland, they introduced free personal care, and the demand for state care in people's homes doubled. It's already huge, but it doubled because people stopped caring for their older people themselves and let the council do it for them. Well, that's not a very desirable thing to happen. The third thing to deal with one canard, nobody, this was repeated on the Panorama, otherwise excellent Panorama programmes the other day, nobody now has to sell their house in their lifetime to pay for care. Very few people know that because the government hasn't chosen to publicise the fact. But If you need care and you go into a home and you have a valuable house, you can borrow the money to pay for care from the local authority, and it is repaid only after your death. It does indeed reduce your dependents' inheritance. I accept that absolutely. But the idea that people are having to sell their homes to pay for care is ridiculous and untrue. So why has free care become fashionable again? This is a bit of a canard, but still. Socialists want free care because they believe that public money grows on trees. And therefore, another 17 billion to John McDonnell isn't much. Conservatives, those on the right, believe in free care because it hugely shifts resources from the poorest in our society to the richest and their heirs. That seems to me to be a poor reason to adopt what would be it's a fatally flawed piece of public policy.
Well, first of all, thank you very much for Policy Exchange for this piece of work and for Warwick for putting it forward. It is the centre of the national debate. It is absolutely crucial because we know the current system isn't working. There are failures within it, there's an unfairness in it, that there's a randomness in it. I will give you a constituency example. I had somebody come to see me whose mother needed nursing care, and they had built a granny annex for the mother, and this was therefore going to be used for paying for the care when the mother died. Admittedly, the money wasn't going to be taken up front. Had they not made it an annex, and it had remained part of the family home, it would not have been liable for a charge from the council. So you do what you think is best for your aged parent, and you get hit later on when the aged parent has to go into social care. That cannot be what a reasonable system is intending to do. So you then look at the solutions, and you have a choice of getting people to pay as they do with a very low hurdle, as Warwick was pointing out. And yes, absolutely, as Lord Lipsey was saying, if you raise that hurdle, you're protecting people with inheritances. But it seems to me that you're not protecting the wealthy, you're protecting the squeezed middle, who are the ones who end up paying for everything. That people who have millions of pounds, the cost of social care is not going to be that important to them. But actually, it's the strivers, the people who've got on in life, the people who want to pass a little on to their children, who you hit dramatically. The people at the extremes are taken care of one way or another. And that in hitting them, you create a desire to organise affairs to avoid it. But you have a randomness, because what is it? 1 in 10 people actually need these very high costs of care. So by an accidental concatenation of circumstances, you find that some people with moderate amounts are very, very heavily hit, whilst other people are completely looked after or don't need it in the first place. And it does seem to me that one of the areas where the state is the right body to be taking care of things is that accidental impact that is unaffordable when it hits. That surely is where the state provides a safety net where we as taxpayers feel that we are right to offer support. And as Warwick's pointed out, an ingrowing toenail will be paid for by the NHS. A corn won't, as it happens. I had a constituency come to me to complain about corns and that they're not paid for by the NHS, but an ingrowing toenail will be. Whereas anyone could afford to have their ingrowing toenail taken care of, but they can't afford to have their social care taken care of. That seems to me the wrong priority. That's not to call for taking away anything from the NHS. It's already there, and to take it away would be a political argument not worth having for any government, certainly not for ingrowing toenails. But that social care isn't covered is the unfairness. And the cost, well, Warwick's paper, I think, estimates £11 billion cost. That is not a small amount. So why am I, as a fiscal conservative, saying that is the right thing to do? Well, I do want an element of co-payment. The report suggests £5,000 a year to be a contribution. I agree with Lord Lipsey that you don't want things to be completely free, because then people do increase their demand. You want to have some charge for it, a charge that is large enough to be recognisable, but not so large as to leave the problem as it is. I think that is the right way to go about it. But I think it's in principle right that the extraordinary risk is borne by the state rather than by the individual. That is a fair pooling of risk. And I want to make one other point, and that is Warwick in his paper does not come out in favour of hypothecated taxation. There are lots of schemes floating around for hypothecated taxation. These are crazy. The Treasury is right. It's not something I always say. But hypothecated taxation is a really bad way of funding anything because you always get the wrong amount of money. You either get too much and then you raid it, as they've done with other hypothecated taxes, or you get too little and then you're trying to work out how to squeeze it one way or another, either by cutting the service or by bringing in more charges or whatever it is. Hypothecated taxation never provides the right amount of money for the service you're trying to provide, and therefore you want it to come from the consolidated fund and not clearly from councils, because council budgets are now going almost entirely on adult and child social care. And that isn't a sustainable situation as far as I can tell. I don't think it's working for councils, many of whom are in financial difficulties. So rational risk for the state to bear, a sensible way of ensuring that people are looked after, and a means of doing it that leaves councils solvent. I think Warwick has a really good idea, and Policy Exchange an impressive idea for how you solve this great conundrum. Thank you.
Thank you. Hello, I'm Camilla Tomini. I'm the Associate Editor of The Telegraph. Thank you very much for having me, Will, and everyone here at the Policy Exchange. In journalism, we always have a tendency to try and put the human being at the heart of every story. So let's try and put the human being at the heart of this issue. And perhaps it is based on a degree of perception, which might not necessarily match reality. But if we look at the Delta polling, which Will mentioned earlier, there is a sense, as you stated, that the readership is extremely concerned about social care. The figures that we published back in June suggested that 69% of all voters and 72% of Tory voters agree that social care should be funded by the NHS, free at the point of delivery. Only 6% of voters preferred the option of social care being paid for by the people who need it. 13% preferred the option of taxes for social care being levelled on people after the age of 40. And most people think any annual charges should be minimal, so with up to £5,000 being the most popular choice. So what that's indicating from the readership perspective is that there is this sense of a disparity between the notion, and it's often cited in stories, that if somebody at the age of 65 is unfortunate enough to have cancer and need care because of such a life-limiting illness, that is a cost that will be covered by the NHS. But if they're unfortunate enough to develop dementia, then that is a cost that they're going to have to fight tooth and nail to get from the local authority, and then have this perception of jeopardy being placed on their own property and indeed the legacy handed down to grandchildren. And from a Telegraph perspective, obviously we are dealing with readers in the AB category who do have assets and wealth. But I think it's worth pointing out, when we're talking about people not being able to pass on equity to children, we are not simply talking about the super rich. The threshold with which people have care covered by the state currently is extremely low. I believe it's 23...
About 24, roughly.
23 or £24,000. Now, most homeowners in Britain will not meet that criteria, but may not consider themselves to be particularly cash-rich. I mean, frankly, quite the opposite. So the idea that already this policy of giving state funding for social care being something that caters for huge swathes of poorer people is a complete misnomer. It's catering for the absolute extremity of poverty, but for not all of those people, not even squeezed middles, I would suggest, but low-income families who may have bought their council houses in the 70s and 80s, and that might well be the only asset that they pass on, bequeathed to their children and grandchildren, probably along with no other assets whatsoever. So the perception clearly from readers is that this is something that seems to be a misnomer in the system. But I think there is a greater issue here if we think about the human being at the heart of it. And it's the sense that readers and people, members of the general public, have a general sense of living somewhat in fear of what might happen to them in old age. And this notion that despite our glorious welfare state that's rightly celebrated by everybody in Britain and is the jewel in the crown of our entire benefit system, not providing the safety net to catch them should something unfortunate happen. Now, you'd regard Telegraph and indeed Telegraph readers and Tory voters to be fairly risk-averse people who would insure against all sorts of different scenarios. They're the kind of people who insure their lives. They may even take out critical illness cover. They certainly insure their houses. They insure their holidays. They calculate against risk. And yet the option isn't available for them to insure themselves against the unknown. We know we're all living longer. We all hope to live long and illustrious lives. Putting my royal hat on, we hope to emulate the monarch in her healthiness at the age of 93. But equally, not a lot of us are that lucky. And therefore, I think there's a sense from readers of actually kind of living in fear of longevity, which from a psychological and societal perspective is really quite damaging. I think Andrew Dilnot, when he presented his findings to the King's Fund, made this point about elderly seeming like a burden on society, when conversely we really should be celebrating the fact that technological advances have produced longer lifespans and more quality of life into pensionable age, not just life-limiting conditions. Putting an altogether different hat on, my father's a retired GP who has historically for the last 40 years run nursing homes and is currently the owner of a nursing home in St Albans. And having had a chat with him in advance of this panel this morning, the point he's making about the funding of care is, yes, that adult social care funding, there is also the CHC funding, which is for more critical conditions. But the actual adult social care funding for patients who he is seeing with extremely complex needs is simply inadequate. He did a local analysis of how much it would cost to put an elderly person in a St Albans B&B for the week. And it would cost more than the funding that is provided by the local authority, which is meant to cover not only food and board, but TLC, occupational therapy, NVQ-trained nursing care, I mean, to the highest quality. He also points out that because people are living longer, their needs are so much more complex that the clinical excellence needed to deal with people in care homes and the standard required of the staff to deal with them has raised exponentially in the last 30 years. So you're also having to recruit the best staff, understandably, who should be dealing with our elderly, and that, of course, costs money. So we have situations where Four Seasons and other groups go out of business because they simply cannot make it work with the funding provided against rising rents, against there is a growing demand, but also at times becoming victims of their own success. I'll give you a little anecdote in Dad's case. They had a patient who came in, Eileen. She came in and she came from hospital where she was in a, I suppose you would call it a bed blocking situation. And they were told she's got life-limiting conditions and she's not going to be here long. And the residents chose the nursing home because they wanted her to have good end-of-life care. Eileen is still at the nursing home 6 years on. That is because the nursing home has provided what, unfortunately, the hospital couldn't, which was TLC, better food, more occupational therapy, one-to-one care. Now Eileen hasn't got the funding to continue because the nursing home has made her better. It hasn't made her better enough to go back to her home, but it does prove that there are facilities in the care system which can help ease bed blocking and give older people a much better quality of life with the safety net around it of clinical nursing experience combined with general TLC and a comforting environment which elderly people can benefit from. But yet there's this huge disparity between the funding that is forthcoming to help. Yet if you look at Eileen, had she have been left in the NHS system, she will have cost the system thousands and thousands of pounds, more so than the clinical environment that she's now in. So we have that dilemma of funding and the disparity between funding and the care needs of the patients to also consider. So in conclusion, the rhetoric around, and let's remember as well that social care isn't just about the elderly, but it's about adults who have disabilities and other conditions, which mean they can't live the ordinary life that others enjoy. I think politically the optics around this are wrong and overtly negative and actually scaremongering by their own fault, because you have people living in fear of getting ill, which in a civilized society seems to be absolutely the wrong approach. And to conclude, I recently had a conversation with somebody who works at Great Ormond Street, and the protocol around dealing with children in illness sets a hugely high bar for the kind of care that quite rightly needs to be provided if children happen to find themselves in desperate situations with their health. And she had made comparisons with how elderly people are treated, and the gulf is enormous. And yet what we're talking about here is the two most vulnerable groups in our society. The idea that, you know, elderly people can just be cast aside because they've lived a life seems to me shameful and shambolic. And from a newspaper perspective, we need to do more on loneliness. We need to be doing more on nurturing elderly people. We recently had all of the coverage of D-Day with these veterans at age 90 possibly attending their last ever commemoration of that particular conflict. And I think it serves as a salient reminder, you know, that in civilized society, if we're ignoring those that have contributed all their lives to society, then we're really letting the entirety of society down.
Thank you. Good afternoon, and thank you to Will and the Policy Exchange for inviting me here this afternoon. I have three asks of a future Prime Minister about social care. And my first ask, I thought, was also going to have to be an ask of the panel, but luckily Camilla has just saved the panel in her last few moments of comment. So the first thing I wanted to say about what do we need from a Prime Minister is we need the Prime Minister to value and recognise adult social care for being a vital service in its own right that provides life-changing support to individuals that find themselves in need. It shouldn't be seen only through a lens of older people and whether they should or shouldn't sell their house to pay for care, or whether older people are in a situation where people call them bed blockers, people don't block beds, the system block beds and causes delayed transfers of care. But too often the debate about adult social care is narrowly about how can you reduce the pressure of older people on the NHS and seeing social care in that way. But it's important we recognise what is social care. It's an absolutely critical service that's provided to older people and working age adults. Half of all of the public spending that goes on adult social care goes towards working age adults, and a higher proportion of working age adults are now seeking and receiving support from their local authority, whereas although the numbers of older people are increasing that are getting support, actually the proportion is decreasing as the local authority system gets meaner and tighter in terms of eligibility. It's also a sector that employs 1.5 million people, so it's a significant employment sector and therefore something where we should be celebrating the difference that those people working in the sector make day in, day out. So that was my first ask of a Prime Minister, is let's value social care for the service that it provides and the support it can help people with their life every day. My second ask of a Prime Minister is an emergency fix to the current adult social care system. Several members of the panel have already talked about the strain that the current local authority funded system is, which is really the safety net that's there to support people with the highest level of need and the lowest level of means. Spending has fallen in real terms, so we are now spending £700 million less a year than we did in 10-11. We saw several years of really, really tight funding to care providers, which Camilla's briefly referred to from her father's experience, where the fees being paid to providers was decreasing year on year, and providers were really struggling to be able to provide the quality of care that people rightly expect. We have, in the last couple of years, seen local authorities recognise that that went too far and start to increase the fees paid to providers, be they in the private sector or the voluntary sector. And last year, for example, fees did increase by 6.6%, despite the fact that local authority budgets overall decreased. Even with that most recent increase in fees, we are still seeing the price of home care, for example, is well below the recommended minimum price per hour, which is again putting real pressure on providers and staff working for them about how can you deliver high quality care. As is true across the NHS, as well as social care, vacancies are extremely high and turnover is very high. So vacancies in the sector at the moment are at 8%. That's about 110,000 vacant roles at any one point in the sector. and almost 400,000 people are leaving the sector each year with a turnover rate of 30%. So we're seeing a sector which is really struggling with recruitment, really struggling with providers having the necessary resources to be able to deliver quality care, and local authorities struggling to be able to provide the quantity and quality of care they'd like. Other people have talked about the eligibility and means test process and how that has meant that a smaller and smaller proportion of older people are receiving help from the state. We see quite a mixed picture about what's the user satisfaction when it comes to social care. So some surveys have shown a fairly steady picture over the last 4 or 5 years, which is perhaps surprising, but I think a really encouraging sign that once people get into services, providers are working really hard to deliver a good experience. But we are seeing some more interesting data around how carers perceive the care that their family or friends are receiving, where that is considerably lower in terms of satisfaction. So a real mixed picture on that. But it seems clear to me that we need significant investment in the current publicly funded system that provides certainty for local authorities and ensures that money flows to providers to be able to deliver innovative, supportive care. My third ask of the Prime Minister, future Prime Minister, is to tackle the question that's been the predominant discussion on the panel so far. So the long vexed question of how to reform the adult social care system, what should we pay for and who should pay for what. I'm not here to particularly promote any individual model. What I would say is the current system is clearly unsustainable financially. It has very little, if any, public support. It is also an extremely poorly understood system. So although I say it has little public support, most people don't think about it. It's only when you tell them what it's about that they realise how unfair the system is. We often, when we think about how to reform social care, the question comes up about this is going to cost money and we can't afford this. Doing nothing will also cost money as well. It will cost money to the adult social care system. It will also cost money to families in terms of the pressure it puts on carers, people needing to leave work to be able to support their family and friends, knock-on consequences to other public services. So we shouldn't pretend that doing nothing doesn't come with a bill. It absolutely does. So we're going to have a Prime Minister that's prepared to accept that this will cost money. Also a Prime Minister that's going to need to accept the low level of public awareness means this is a very challenging policy issue to take the public, the media and Parliament with you on the journey of reform. We have got to the starting line over the last 20 years on several occasions. We've got halfway through the race. We've even at times got quite close to the finishing line. We have legislation on the books about a particular funding model, but we've never got to the actual finishing line of implementing a model that can work. So we need to have a serious debate in the country about how we want to pay for care, what the right balance is between the state and individuals and families. We need to accept that no model is going to be perfect. Perfection isn't the exam question. Better than the current very, very imperfect model is the exam question. And we need to be looking at proposed solutions through different lenses of fairness, equity, ease of use, economic efficiency, value for money and sustainability. We need to recognise a solution will be a compromise amongst all of those lenses and will never be perfect across all of them. My final point about long-term reform is we seem to have made it astonishingly difficult to make a breakthrough in this in England. Other countries have done this. They have been able to, as a country, come together and have a grown-up conversation about what an ageing population means for how we pay for care. So this isn't rocket science. We should be able to do this if we show committed debate, seeing it all the way through to a fair compromise that can change the current system and mean that the care system can confidently plan its future, being able to deliver services with people that can absolutely transform people's day-to-day experience of their life. And I think the quality and the impact of good social care we absolutely shouldn't forget, because it can be life-changing. So my 3 asks of the Prime Minister: value and recognise social care for what it is. It's not just an add-on to the NHS. Provide some emergency fix to the current system and begin and see all the way through a debate and a conclusion about how to pay for care in the future. Thank you.
Well, thank you, Sally, and thank you to all the panellists for those excellent contributions. I would like to throw the debate open to the floor now and take questions. I'll try and take sort of 2 or 3 at a time because we've got about 15 minutes left. So hands up, anyone who'd like to ask a question. 2 at the back, just there.
Hello, thank you to everyone. Samantha Nicklin from the Alzheimer's Society. So earlier this week I went to visit a gentleman who has young onset dementia, and his family pay £1,000 a week for his specialist care. His family will run out of money in November, so it really pressed on me the urgency with which we need to find a solution to the problem of social care. Considering the social care green paper has been delayed for now 2 years, and the Health Secretary gave evidence to a select committee within the law that there was a lack of bandwidth because of Brexit in order to solve this. How realistic and likely do you think it is that we will find a solution to social care shortly, soon, urgently?
Thank you. And there was someone else at the back. Yeah.
Hi, my name is Nathan Hollow. I advise some of the largest care providers on their media and politics or political engagement. One of the things I think is often left out of the debate is the significant capital expenditure that's going to be required in the social care sector in the coming 10, 20 years. 80% of care homes in this country are over 50 years old and are coming to the end of their operational lifespan. I close hundreds of care homes in a year for various different providers as a result of a lack of the current funding. But when people talk about future funding solutions, they don't factor in the significant costs of rebuilding or reconfiguring services to meet current and future quality needs. So how can the system, when we're already struggling to find a solution to meet today's funding needs, actually factor in capital expenditure?
Thank you. Warwick, do you want to start with?
Well, I'll start with the first question. One of the things I always emphasise when we talk about long-term social care is we tend to think of it someone in their mid-80s, someone like my mother in their 90s. But actually it's a much broader spectrum than that. And that young man you refer to, if I caught it right, will be young, he has dementia. I first met a 25-year-old with dementia when I was a hospital messenger in Plymouth General Hospital, and I went into the geriatric ward and I saw someone there very different from normal, sitting up in bed, smiling, and I said, why is he here? And it was explained that he had a very unusual early onset dementia, which in those days was much rarer. You also have examples where you have a husband and wife or a couple where one of them gets a nasty version of Parkinson's disease. It goes on for a very long term. Now, they don't lose their house, but they're subject to a means test, and the means test affects both the incomes of the husband and the wife. I met a journalist at the LSE at a conference on Monday who gave the example of her own husband, where basically all that household's long-term savings were, as you put it, simply cleaned out. I don't know what the answer is in terms of the timetable for making progress with this, and I think it would be wrong to mislead you that it would be expedited. But maybe there are other people here who've got a better sense of that than I have in the politics of it. In terms of the capital, I understand entirely what you're saying about that. One of the big reasons why there was a move from local authority to provision to voluntary organisation and private provision was that local authorities had homes that didn't match the standards of inspection, largely because of the physical fabric of the buildings, and that's why after 1990 there's a big shift across. In some respects, given that the public sector will have the capacity to borrow a little bit more in terms of very low rates of interest, and that will also help the private sector as well, maybe some of the capital constraints that we faced in the past won't be quite so acute, because some of the spreading the costs of capital through borrowing may be a bit easier than it was 20 years ago.
Lord Lipsey, I was wondering if you had any thoughts on the first question in particular.
Yes, I do. Progress is very dependent on all-party agreement, or trying to get nearer to all-party agreement. We've had 2 lots of proposals shot down by death tax, dementia tax, people making capital out of this. I don't think talks between the parties have been well structured on this. I think if you'd appointed a good mediator between the parties, it would have had a much greater chance of success, and therefore getting something that would last. The second thing I'd say, which I would, wouldn't I, but still, The more ambitious the proposal you have, the less likely it is to happen quickly. If you're going to have free care for everybody and a huge change in public expenditure in that direction, this is not likely to happen quickly. I personally think that Deal Not as amended, i.e. with a higher cap than Deal Not recommended, came as near in the practical world as you can get to having something that would work for now and would deal with many of the immediate problems of funding care.
I'm interested to know actually this point on ambition, Jacob. Do you think there is a sense of ambition from the candidates for the Conservative Party leadership, who are obviously going to be the next PM, to solve this, or are we going to see a continuation of what we've seen in the last couple of years, which is, the green paper promised by the autumn and then by Christmas and then by spring and never quite appearing like a sort of bad Uber ride? I just wondered what you thought about that.
Having just crossed the taxi protest, I'm not going to talk about Uber. I'm on the side of the black cabs. I think the bandwidth answer is such a dreadful one. I mean, I probably think about Brexit as much as anybody, but that doesn't mean that there isn't time to think about these other pressing political issues. And there just ought to be an ambition to deal with it. Politics isn't so narrow that it can only deal with Brexit, and it's a matter of political willpower and political energy and drive, and I hope that a new leader will bring that. And I think the Alzheimer's case shows the absurdity of our current system. Why is Alzheimer's clearly a disease deemed to be social care when, if it's cancer, you're in hospital and it's all paid for? There's no logic in that. And to go back, Camilla quite rightly said this is ultimately about individuals. And I have people coming to see me who have abstruse arguments with the NHS as to what percentage of the care they are having is medical and what percentage is social. In the end, this is entirely arbitrary. It's not something you can say, this is medical and this is social, and be certain that that is a factual and right answer. And that's why I think it is urgent to do something, and there needs to be ambition. On capital costs, can I answer that as well? I mean, this ought to be in the price. That what's charged every week ought to make sure that the return on capital employed is a justifiable return and that the private sector can do that, and that's a completely routine business structure. So I don't think there's any problem with that.
A couple more questions from the floor, if I may. Gentleman here at the front and halfway back.
Thanks very much. Jeremy Thomas, Interested Spectator. If I might return to Warwick's point about technology. Given the great advances that the Japanese electronics industry has made in robotics and the greater role that robots are beginning to play in old age care in Japan, I can't claim to be a great specialist in this subject, but this is simply sort of looking at it at FT level. How far is there scope for further cooperation between our own government and the Japanese government and the appropriate companies in Japan who've developed this technology? And turning to the lady to Camilla's left, whose name I unfortunately forget. Sally Warren. Thinking of the difficulty that we have had in developing a unified approach between government, local authorities, and other actors in this particular over this particular issue. How far might practice in Japan, seeing that they have the process of societal aging has gone further there than it has yet done here or elsewhere in Europe, might we not look to them to see what lessons their experience has for us? And they are, after all, without going into Brexit, an island power off the coast of a much larger continent, dare I say.
Thank you. And then a gentleman halfway down the back. Just there, sorry. Oh, sorry. Yeah, thank you.
Hello, my name's Caroline Abrahams. I'm the charity director at Age UK. I'm one of the advisors to the government's Green Paper, and I'm the co-chair of the Care and Support Alliance, which represents 85 charities campaigning in this space. And the first thing I wanted to say was I loved the report, and had the government asked
Thank you.
Warwick to write the Green Paper, I really wouldn't have complained. I think it's excellent. Two of the things that I think are really good about it and very important for what goes forward are firstly that I'm not that bothered about whether care is free or not, actually. What I do care about is that A, we pool the risk, and that's what you've called for. And secondly, that we pay at a different time from when we need care. Because what I personally see from my own family's experience, but from many other older people as well in particular, is that very often people start to need care at a time of crisis because they have a fall, they go into hospital, that sort of thing. And expecting them and their families to make rational, sensible, life-changing decisions when there's so much money involved at the same time is just frankly unrealistic. The other thing I think is really interesting about your report is it's not very different from the report that IPPR on the other side of the political spectrum also produced a few months earlier. So whether you call it free care, pooling the risk, social insurance, it's free at point of use, whatever, I think there is a coming together of opinion formers on the left and the right. And with that in mind, I wanted to ask you, it's a political question, what scope you think there is actually for brokering a more grown-up debate in this space, and what you think people like us, my friends Sam and me and others who are campaigners, can do to actually support you in getting this over the line.
Thank you very much. I might go to Sally and then Camilla, if that's all right.
Yeah, thank you. Jeremy, your question about technology and in particular looking to Japan for how we can learn about ageing, that is something that there's already been quite a lot of looking to Japan. So be that adult social care policy or dementia policy, we have been looking to understand what is it that Japan does from a societal point of view as well as thinking about its service delivery model. So, for example, the Dementia Friends model that Alzheimer's Society has been promoting for several years in this country has its genesis in Japan, and how that country's been thinking about how to create partnerships across government, community and families. So I think absolutely we should be open to looking internationally about how do systems, how have other countries grappled with an ageing population, set themselves on a path to have a reformed adult social care system, and also how have they thought about how can health and care work better together, so an individual experience, because very few people have only social care needs or only health needs. They might have health needs on some particular day, so it's from an individual point of view, it can be quite unsatisfactory to have to navigate your way through the system. Caroline, hi, thanks for your question. I think that the point you made about how you can support that kind of more grown-up debate is absolutely critical. I was going to refer to the earlier question, so I think part of the issue about ambition and urgency is my reflection on the last 15 years of trying to get reform over the line, is a government tries this only once and gets burnt and runs away from it. And we've got to make sure that if the next government tries this, they don't get burnt. And part of that is about how can we make sure there is a honest conversation amongst the sector, which is very diverse and doesn't always speak with a united voice. And actually we all have to recognise we're not going to get absolutely everything we want. We need to have a compromise. So how can we create a space to have conversations that allow us to work through those compromises? How can we, I'm sorry to say it to the journalists in the room, but how can we educate the journalists to mean that we can then have a grown-up conversation about what these reforms mean? Too many of the policy attempts have fallen because they've been caused to call a death tax or a dementia tax, and sorry, Will, you
Guilty as charged.
You didn't invent the term in 2017, I can assure you. It's flying around adult social care policy.
Okay, fine.
So don't worry.
It's a relief, actually.
That is fundamentally a problem if people are not comparing future changes to how bad the current system is. Any system which is going to be about paying more, be it the state or the individual, it's really easy to knock it down, and it's really easy to get into who should pay for that and is that the right share. We need to create an ability for people to bring the ability to compromise to the table. That isn't just politicians, that is the sector as well, and that's service provision, but also the kind of age groups, disease groups really having to come together and think what's the best compromise, because we can't keep not solving this. We all agree that the current system cannot continue. Let's hold that together and agree that a best solution for the future.
On the issue of communicating the policies better, I mean, even Jacob would have to agree that the manifesto was a car crash, and that aspect of the manifesto manifesto. I mean, talk about the media trying to sell it. You couldn't even get MPs trying to sell it in huge Tory constituencies because it was mishandled, miscommunicated, and not very well explained to anybody, including actual backbenchers. And that's when we saw that entire campaign take a nosedive because Tories weren't able to justify their own policy on the doorstep. Hot off the press, I have my notebook here because I did phone Matt Hancock's special advisor before I came to find out what was going on with the Green Paper. And I think the perception of can kicking, again, is very, very difficult for the media to spin any better than just procrastination and delay and the handling of a hot potato that they see as politically contentious rather than a grasping of the nettle approach, which is actually what the general public wants. And essentially, yes, the word bandwidth was used. It was 90% ready to go in November. The contentious part of it all is the funding. We're trying to have 4 or 5 different models of funding so that we can start a national debate. I felt like saying we've been having a national debate about this for 20 years. And equally, of course, once a decision is made or a proposal is made for funding models, you would then get the financial services industry coming up with products. And the former Pensions Secretary, Ros Altman, has made a great many suggestions of the kind of financial products that could be made available for the public so that they can make a choice. Does a 30-year-old want to take out a tax-free ISA for care, which was one of the recommendations, and save up money? And could the government be inventive in its fiscal policy of making suggestions like, well, actually, if you're lucky enough to not use that on care, you can actually pass it down to the next generation should they run into difficulties in older age? That would be a good tax incentive. You made the point about capital investment in older properties. Dad's nursing home, funny enough, is a converted Bishop's Palace, so it's a very, very old building. And by the way, that isn't a barrier to providing a great environment for care. Actually, older people do sometimes feel alienated if their environment is a bit too futuristic and kind of has the clinical hallmarks of somewhere that is more modern. And there's ways of adapting places, but is the Treasury then able to offer tax incentives, VAT breaks on renovating properties for nursing care, or do other more creative things to incentivise the care industry to reinvest in its own world? So I think that's a significant thing. Yeah, I think that's the points I need to... Oh, and I was going to say on the Japanese idea, you know, we are pioneering AI ourselves. Yes, let's look to the Japanese, who, from a societal perspective, have a different attitude along with quite a lot of Southeast Asian countries to how they treat their elderly. And a lot of elderly relatives are looked after in the home of a lot of different societies. We're not necessarily going to adapt to that model because of the circumstances many face themselves in. They don't have big enough accommodations for their own families, let alone having parents come and stay with them. But is there more of a national conversation we should start about taking more care over speaking to the elderly, including the elderly, the loneliness agenda? And is it politically expedient? You know, often politicians say, well, that's not going to meet not going to win many votes. And then you actually look at it and you see that that's a cross-generational, cross-demographic issue. Young people are concerned about their older relatives. Older baby boomers are concerned about their own parents and having to look after them. This is something that comes full circle, and I would suggest is actually politically expedient to have policy on.
Thank you very much. Well, I think we've got a real sense today that if the new Prime Minister thinks that Brexit is the only thing in their in-trait, they're going to be in for quite a big surprise. Social care is clearly among the great sort of policy challenges of our time. So I think I'm a stickler for timekeeping, and we've got a third event coming pretty close after this one. So I will just ask you to thank our panellists in the usual way. Thank you all very much.